Hi, everyone. So I'm going to be talking about health equity, and then we're going to be talking a little bit about hepatitis C as sort of an example of how health equity plays out in our communities. And then I'll be passing the mic on. So I hadn't realized that we were going to be doing this webinar style, so you won't be able to answer my question, but that's okay. I have many answers in my brain already. So we usually start with health equity in HIV Edmonton's work because we have spent a really long time when we think about STIs thinking about individual health behaviors and sort of what we can do as a person, an individual, to prevent STIs. So things like testing, condoms. Oh, the chat is open. Great. Treatment. But what we find is that when people don't have access to these prevention strategies, they are actually really limited in how they're able to engage with their health. And so HIV has sort of become something that is more of a health equity issue rather than an individual sort of behavioral issue. So now that the chat is open, or now that I'm aware, we're going to think a little bit about what equity is. So if you'd like, could you share some words that you think of that come to mind when you think about equity? I've got fairness. Thank you. Oh, we're quiet. That's okay. Fairness is something that comes up a lot. I think fairness is sort of an interesting one because what is fair kind of depends on our perspective. That'll come up on the next slide. Something else that tends to come up is equality or inclusivity. These are sort of the words that people come up with. So here is a version of a slide that you've maybe seen before. This is from an Inuit health promotion organization, and it's sort of describing the difference between equality and equity. So when we're concerned about equality, we're concerned about everyone getting the same resources. That's what fairness is in this model. So here we can see 3 different people, they're all different heights, and everyone is trying to watch a hockey game. In an equality framework, everyone is getting the same step stool, regardless of what their actual need is. So a tall person who doesn't really need a step stool gets a step stool. A short person who maybe needs more of a step stool is only getting one and still isn't able to see the hockey game. And so if we think about the outcome here, the desired outcome for everyone as being able to see the hockey game, we're not really there when we think about things through equality. Thinking about that idea of fairness, like my parents, for instance, would think of this as fair. Everybody's getting the same thing, and so that's fair. If we think about equity, now we're thinking more like, what do we need to give people so that they're able to achieve the same result? We're more results oriented. So here, some people aren't getting a step stool because they don't really need one. And some people are getting 2 step stools because that's what they need. So here this is really focused on what people need to be able to achieve that result. And if we think about it within a health context, that outcome that we're trying to get to is health. So we're asking the question, what do we need to give people so that they're able to achieve that outcome of health? I also like to open up the idea of health. Sometimes when we're thinking about health, we can get really focused on kind of our own perceptions of what is healthy or what a desirable health space is for someone. But especially in communities where people are using substances or we have different cultural understandings of what health is, we might not all see health the same way, and that's okay. So health equity is grounded in fairness and justice. We're coming back to that word fairness again, right? It acknowledges systems and histories of inequity and it works to address them. So it's saying what got us here and how can we address those issues so that everyone is able to access health the same way. If we think about, say, the way that Indigenous folks have been treated within the healthcare system since Canada's inception, right? We used to have hospitals that were segregated just for Indigenous people, and the care that they received there wasn't the same as the care you would receive in like a white or a settler hospital. And we see how that plays out today, and we need to work to address that. Health equity gives people the ability and access to articulate their needs. And I think that articulation piece is really important. We're asking the question, what do you need to get to where you want to go in your health? And we're really centering the person that we're talking to and their own ideas about what it is to be healthy and their own goals for themselves and their life. Health inequities are systemic, so that means that they're coming from the systems themselves. We could intervene with a million different behavior interventions for people. We could do a bunch of trainings, but at the end of the day, our systems are still where the flaws are. So those things are all really great, but if we don't change the systems, we're not really going to be able to get to this equity place. They're unfair and they're unjust. If we think about that idea of outcome, right now in the system that we have, not everyone can achieve the outcome of health within sort of the system that we have and the way the resources are being distributed at this moment. And finally, they're avoidable. So if we really centered individual needs, if we really put a lot of money and time and effort into dismantling and changing and reconsidering our systems, we would be able to get to a place where everyone has access to health. So we're going to shift. It's going to seem like a weird segue, but it'll make sense in a moment. Hepatitis C is a really good, I think, example of how health equity plays out in our communities. It's a viral infection of the liver that's passed through blood-to-blood contact, and it's not one that you often hear about. I know in my sex ed days in school, nobody ever talked about hepatitis C with me, and so we like to spread the word. It's part of HIV Edmonton's mandate. So how is Hep C transmitted? These are the ways that we see it transmitted most often in Canada. The first is through shared drug use equipment, and Hep C is quite a robust virus, especially compared to something like HIV, which can only live about 30 seconds on a surface. Hep C can live up to 6 months on a surface. So it's anything that comes in contact with blood that we might use to use drugs. So this could be needles, syringes, cookers, tourniquets, and also pipes. If we think about someone who has a lot of cracks in their lips, which is really common, especially when people are outside a lot, if I have cracks in my lips and I use my pipe and then I pass it to you and you also have cracks in your lips, we can have blood-to-blood contact without actually sharing a needle or something like that. It's more rare, but it does happen. Oh, my slides are being funny. Of course they are. There we go. Shared shared personal items like toothbrushes, razors, nail clippers. These are hygiene items that often people who are unhoused have a hard time keeping or having access to, right? So we might think about something like a toothbrush. If you get a toothbrush at HIV Edmonton, say, you might be like, what does that have to do with health equity? But we're preventing hepatitis C when we give someone a new toothbrush or a new razor. We can see Hep C transmission through sex when there's a chance of blood. So this could be sex during menstruation or during anal sex. Anal sex can cause little tiny fissures on the inside of the rectum. And the penis can also develop little tiny fissures because of the friction. And so, especially if we're not using a lube or we're not using condoms, especially, we can have transmission through sex. We also see Hep C transmission through unsterilized tattoo and piercing equipment. I have teenage kids, and right now they are obsessed with giving each other stick and poke tattoos in each other's basements. And it makes me nervous as a health educator because I'm just like, oh, you want to see whoever's giving you that tattoo or that piercing, take the needles out of the package. That's how you know they're new, which is what you want. We also see transmissions in medical procedures. In places where Hep C is common. This is often due to a lack of resources. So people are put in positions where they have to reuse medical equipment, or they aren't able to test blood transfusions for Hep C. And so they're unintentionally transmitting it. If I was in a situation where I had to make the choice between getting a medical procedure that I really needed or a blood transfusion that wasn't tested for Hep C or dying, right, I would probably take that blood transfusion and deal with the Hep C later myself, but we all get to make our own choices about our health. And in Canada, we had transmissions of Hep C through blood transfusions, but before Hep C was discovered in 1992. So this was a way that unintentional transmission. Well, I mean, all transmissions are unintentional, but this is a way that our medical system also contributed to Hep C transmissions. So in Canada, more than half of people with Hep C don't have any symptoms. And so this is a big barrier for people, right? A lot of folks think that they'll know when they have an STI because they'll have those symptoms. And it's just really not that simple. If we look at the symptoms, the first row of symptoms here, we have really common liver symptoms, right? Jaundice, dark urine, light poop. And then the bottom, we have these more vague symptoms: nausea and vomiting, loss of appetite, extreme fatigue. When I look at these bottom row, especially symptoms, I think of COVID myself first, right? That's kind of the world we're living in. And I think that if someone was to present with these symptoms, they would probably think, they wouldn't be thinking about Hep C, right? So testing is going to be really crucial here because that's the only way to know for sure. And waiting until we have symptoms might be not the best strategy for this. So how do we prevent Hep C? The first and best way is to use new drug use equipment every time. There's lots of programs in the city to access new supplies, including at HIV Edmonton. We want to use condoms for anal and menstrual sex. We want to make sure that people have access to personal care items that may come in contact with blood so that they're not having to share them. We want to make sure that we're using new equipment for tattoos and piercings, and that we're encouraging testing and treatment. We're in this really great place with Hep C treatment where treatment cures 95% of infections. So if people have access to treatment, it's highly effective. But that's the thing, the access issue. So this is from a paper that was published in 2019, and it's from Alberta. So this is a really local, I think it's funny that we're talking about this in a global health context because this is a really local example. So this is what we call the cascade of care for Hep C. So these are all the steps that someone has to go through if they test positive for Hep C. In the first bar of this graph, we see 100% of the people in the study, they all tested positive on an antibody test, but that just tells you if you've had Hep C at some point. It doesn't actually tell you if you have Hep C right now. So the next step is an RNA test. So this is the confirmatory test that says, like, do you have Hep C right now? Only 69% of the people who tested positive on the antibody test made it in for this RNA test. Some of those people are going to test negative because they had Hep C at some point and they don't anymore. So for the rest of these bars, I'm only going to be talking about these true positive people. The next step is genotyping. So this is where they determine what strain of Hep C you have, which is important in treatment. Only 73% of the people who had the RNA test went through with the genotyping. Next, folks see the hepatitis specialist. 89% of the people who got genotyped saw the specialist. And here's where things really start to drop off. The next step is actually getting that antiviral prescription, and only 34% of the people that saw the specialist went through with the prescription. And when we compare the number of people who actually cleared their infection to the people who got the prescription, only 29 people were able to do that. So thinking about these people who were able to clear their infection and comparing them to the people who tested positive on the RNA test, we find that only 10% of folks who tested positive on the RNA test were actually able to clear their infection. So in the chat, I want you to tell me, why do you think, what do you think is causing poor retention in Hep C care? What problems can you kind of see in this graph that might be contributing to this, this substantial drop off? Too many steps, yeah. When I look at this, I'm overwhelmed myself. And this is only the like broad steps. We know that in here, you know, there's visits to the lab, there's visits to the pharmacy, there's multiple appointments, there's follow-up appointments. There's a lot of steps here. Papa Swan is my favorite participant because they give me lots of answers. Does anyone else have any ideas about this? Access, time, yeah. Where are the clinics? When are they open? Do you have to leave your job to get there? Do you have transportation to get there? We've also got health education and health literacy. Yeah, if nobody sits you down and says, these are the steps you need to go through, and here's all the people you need to call, and here's like the cascade of care, and you're going to do this, it's really hard to know that you need to do this. You might not understand the long-term impact of Hep C either. If nobody tells you, we know that physicians are often really overworked. They have really short amounts of time with people, and they might not understand kind of where somebody's at when they're talking to them. So that's a big problem here too. So these researchers, O'Neill and colleagues, they looked into this in their data set to try to figure it out, to figure out sort of what was determining people's ability to stick with their treatment. So they found that men were more likely to stick with treatment than women. We know that women experience a lot of patriarchy within the healthcare system. They might not feel respected, they might not feel heard, especially if they're dealing with a male clinician. Age. Folks who were older were more likely to follow through with treatment than people who were younger. We know older folks are a little bit more aware of our mortality. Younger folks tend to feel a little bit more invincible. Older folks might have the social structures and the transportation, and they're more settled in their lives, where a younger person might not be in that same place, that they might not be able to go to all these appointments. They might have a job where they can't leave as easily as someone who's older and a little bit more established. Income. Folks who were poor were less likely to follow through with treatment than people who had more money, right? We need money for transportation. If nobody tells us that Hep C treatment is free, we might avoid getting that prescription, even though we actually wouldn't even have to pay for it. If we think about where we might live in the city, if we live on the outskirts of town because it's cheaper, it might cost us a lot of money to get into the city to be able to actually go to that Hep C specialist appointment or something like that. Comorbidity. So people who had liver problems already were more likely to follow through with Hep C care. I think this makes a lot of sense. You're already thinking about your liver, you're already concerned about it, you're already connected with liver specialists, and so you're going to be a little bit more engaged. Race. Indigenous folks were less likely to complete treatment. This isn't anything to do with Indigenous folks. This has to do with our systems and the way that Indigenous people are treated within them. If you experience racism or perceive racism within that medical appointment, you might not go back. It might not feel safe for you. You might also be carrying sort of ancestral trauma when it comes to our systems because there's been so much harm done and not a lot that's been done to repair that harm. Folks who were unhoused were less likely to engage with treatment than folks who were housed. If you're unhoused, you're thinking about where you're sleeping tonight. You're thinking about where your next meal is coming from. Your life is kind of dangerous and kind of scary, and you have a lot of things on your plate. So you're not really probably thinking about your liver that much. As well, when people are unhoused, their stuff gets stolen a lot. And so even if you had your meds, they might get stolen, and they're not even really fun meds to steal, but that's just what it's like out there. This is why programs that are like wraparound programs, like what we have at HIV Edmonton, are really valuable. And substance use. Folks who drank alcohol were less likely to engage with treatment than folks who didn't. If I was drinking and I was concerned about what that liver specialist was going to tell me, right? We know, people know if I go to the liver specialist, they're going to tell me to stop drinking. And if that isn't something that you feel able to do right now, you might not go. So this is kind of what we see. All of these different aspects of our identity intersect to create a really specific experience that we have, and it can impact the way that we're able to access health. So I just want us to think more in a positive way now. Let's dream a little bit. If you were accessing health and it was equitable, what would it feel like for you? I really want those feeling words. How would you feel if you were able to access health in an equitable way, in a way that felt safe and welcoming to you? Empowered, right? Especially when we have that space to articulate our needs. Our clinicians are really listening to us and they are understanding where we're coming from. Respected. Yeah, respected is a really good word for that, right? We feel like we have autonomy over our bodies, and that does help people engage with care. So ultimately treating people with that respect will end up with better health outcomes anyway. Yeah, other words that come up for people sometimes are safety, feeling included, feeling able to sort of put our health at the back of our minds a little bit, because we're not worried about it, because we know exactly what's going to happen when we go to the doctor. We know that we're going to be respected and we have a team that's taking care of us. Thanks, everyone. So really, at the end of the day, health equity exists when all people can reach their full health potential, and they're not disadvantaged from attaining it because of their race, ethnicity, religion, gender, age, social class, socioeconomic status, sexual orientation, or other socially determined circumstances. So at HIV Edmonton and for SIHA too, I know we're all working towards this and to try to get us to a place where everyone can access the health care that they deserve. Thank you.
I'm going to be introducing the next topic. Where we are continuing to talk about, as Jonah talked about, the intro, equity and hepatitis C and all the barriers that have caused kind of a bit more of the stigma to happen and lack of access. And I'm going to be talking about syphilis more so. So in Alberta, the rate of syphilis has increased over 10 times since 2014, where there was only 160 cases. And it's been a 167% increase. The syphilis outbreak in 2009 had 2,265 new cases. And in 2020, there was a reported 2,500 new cases. And the Canadian statistics has found that syphilis disproportionately affects men in Canada, particularly those over 30, and that it increases the risk of contracting or spreading HIV. And also not everyone infected will develop symptoms, which is common with any type of viral or infection as well. And this is just an overall chart of the provincial and territorial rate increase percent from 2014 to 2018. So it just so happens most of us are probably from Alberta, presenting at the U of A, and we are in the lead in this sense. Alberta's rate has increased 831%, compared to 2014. And the risks and health that are associated with syphilis, it can result in neuropathologies, decreased visual acuity and hearing. And there's also congenital syphilis, which it can result in stillbirth and birth defects in pregnant women. Up to 40% of babies with infected mothers are stillborn. It increases the HIV transmission and acquisition risk. It's talked about in the previous slide. There's 4 stages: primary, secondary, latent, and tertiary. And the tertiary stage can affect the brain, blood vessels, heart, and bones. And if untreated, could lead to death. So stigma, as we're always talking about in this presentation, is a socially undesirable attribute of individuals or groups associated with isolation, rejection, and discrimination. And in the sense of having an STI, I think it would kind of hit all of those notes, which is why there is so much stigma attached to it. Nobody wants to talk about it or say if you have something, it's not something that's embraced or considered a good thing. So there is a lot of stigma and rejection and discrimination associated with something like that. And despite strides in understanding STIs and stigma, it's still a global health inequity that has actually just continued to worsen in recent years. And stigma is an essential contributor in the web of STIs, flourishing with other inequalities such as social class, race and ethnicity, immigration status, gender expression, and sexual orientation. And stigma does cause many people to avoid seeking STI-related services because of experiences such as discrimination, indifference, and hostility, as Jonah also talked about a lot in his presentation. And this slide is showing on the left the syphilis in Alberta just per zone. So you can see kind of where Edmonton, Calgary, in between in central, south, and north where it lies. It does appear that the more north you go, the higher the rates are, which could be also associated with the access to care. It does get a lot more rural as we get more north. So that's probably a major reason. And also on the right, the number of early congenital syphilis cases. This diagram is just showing the rate per year of women that had congenital syphilis and their babies, and which ones were live or stillborn birth. So it is a really serious problem that should be screened immediately if women are pregnant as well, which may not be something people are thinking about. And the risk of transmission by syphilis stage is 70 to 100% with primary, and then it does lessen as the syphilis becomes more latent, but it's critical within the first few weeks to be diagnosing and checking for this. And other infectious diseases, since I did want to touch a little bit on a couple other ones to show that kind of over time, everything is increasing, not just syphilis. Chlamydia rates have also increased by 40% from 2009 to 2018. And you can see that the rates are disproportionate in this sense between men and women. Also, chlamydia is more common with women, while gonorrhea is more common with men. And the rates of gonorrhea have increased 190% from 2009 to 2018. So it's also both serious issues, and it just appears that people maybe aren't screening or checking. And I'm sure, as we've talked about, there is a long list of reasons almost for that. So for prevention for syphilis or any STI, the risk reduction, encouraging harm reduction and couples testing, risk factors, new or multiple partners, condomless sex, substance use and or previous sexual transmitted and bloodborne infection, also known as STBBI, open and safe conversation, importance of partner notification and treatment, I think this is really hard. I don't think a lot of people feel very safe or open to have this conversation. But hopefully with time, maybe things will very slowly and eventually change. Repeat screening when at higher risk. Treat sexual contacts who are within the 90-day period without waiting for results. And follow-up testing. Even if there has been treatment, to be doing follow-up testing and make sure that it's still being treated and making sure that it is cleared is also very important. And treatment, the signs and symptoms, you may also be asymptomatic, and that's why frequent testing is also recommended. Antibiotic treatment, the CDC recommends 3 doses of long-acting benzathine penicillin G, and then it takes about 10 days to treat. So there is some self-diagnosis underway. The Center for Disease Control and Prevention recommends to address STIs during the COVID-19 pandemic in 3 different ways. One would be to allow walk-in STI testing and treatment, which over COVID has definitely caused a huge barrier in these things. A lot of people aren't wanting to leave their houses or even wanting to go into a clinic. There's a lot of other fear around that, which are contributing to the rise. And then number 2, partner with pharmacies and retail health clinics for STI services. And then 3, expand telehealth options and self-collection and self-testing to ensure access in underserved areas. And then the benefits of self-collection would be to eliminate access barriers such as stigma, shame, negative interactions with service providers, concerns about privacy and confidentiality, inaccessible hours, and travel time to clinics. So there is a study underway in Canada for syphilis in Alberta. It's evaluating 2 dual HIV and syphilis tests, and its target was 1,500 participants, and it is near completion. They said that it would be projected to be done February 2022. And they anticipate that both kits will be Health Canada approved before the end of 2022. So that's super exciting, and I think would be extremely helpful to be having kits and self access to be able to treat these things yourself, just like COVID, and having a self-test that way. And yeah, I'm going to present that slide right at the end. This is the acknowledgements for my part of the presentation. But I know Rima is going to be presenting a little bit more on the stigma and mental wellness as well.
Awesome. So yeah, hi everyone, my name is Rama, and I'm going to be presenting on STI-related stigma and barriers to treatment today. So I'm just going to start by defining what is stigma. So stigma is defined as negative attitudes or discrimination against someone based on a distinguishing characteristic such as mental illness, health condition, or disability. Social stigmas can also be related to other characteristics, including gender, sexuality, race, religion, and culture. Stigma is often recognized as a barrier to prevention, management, and treatment of sexually transmitted infections and bloodborne infections such as HIV, hepatitis B and C, human papillomavirus, genital herpes, and syphilis. Important barriers to testing, like I mentioned, include social stigmas, but can also include a mixture of societal stigma and personal fears around receiving testing and private care. Stigma often causes many people to avoid seeking STI-related services because of experiences such as discrimination, indifference, and also hostility. So factors that contribute to stigma. So prior to talking about the factors that contribute to stigma, I do want to address that certain groups are disproportionately affected by STIs, largely due to negative social determinants of health, which can be social or economic. And these affect health outcomes, have a huge influence on health inequity. And groups that are most impacted by STIs are oftentimes adversely affected by social determinants such as gender, disability, geographic location, and also sexual orientation. So that being said, I will be addressing a few factors that are contributing to STI-related stigma currently. So first of all, providers are often, they're very uncomfortable in discussing sexuality or substance use. People feel ashamed that they may somehow be damaged and how this might affect their future or current relationships. There's a lot of social norms stipulating that individuals affected by STIs are to blame due to participation in activities that are deemed morally disreputable, such as sexual promiscuity or substance use. There's a lot of organizational policies and procedures that inadvertently contribute to stigma. For example, within health and social service settings, there There's often a lack of inclusive language in intake forms, and there's often penalties for missed appointments, and staff sometimes lack training on issues that are related to cultural safety, which are practices designed to make like client patients feel comfortable, as well as stigma reduction. There's also a lack of culturally inclusive resources that can create barriers for people from diverse backgrounds to seek help. For example, as someone from a South Asian community, it's often difficult to be able to access resources that are more like culturally sensitive for myself. So this was an interesting diagram that I found. And it kind of talks about the layers of stigma, because stigma doesn't occur in isolation and can compound to other forms of stigma and oppression, which can also include stigma against injection drug use, stigma against sex work, racism, sexism, and homophobia, ultimately resulting in experiences of layered stigma for individuals who may have more than one stigmatized identity. This diagram kind of is a conceptual framework which highlights the various forms of stigma that kind of intersect with one another. And you can kind of see how the way they're confronted in society are through like policy, legal, institutional, community, interpersonal, or individual basis. And as you can see, in terms of intersecting sources, we have ableism, homophobia, transphobia, sexism, classism, as well as racism. So harmful effects of stigma and discrimination. Stigma and discrimination can often contribute to worsening symptoms and reduce likelihood of treatment. Effect of stigma can include reduced hope, poor health and well-being, lower self-esteem, difficulties with social relationships leading to social withdrawal, reduced likelihood of staying with treatment, difficulties in workplaces and personal lives, and a reluctance to seek help or treatment, or people being less likely to stick with treatment. Additionally, some of the psychosocial effects may include guilt, embarrassment, isolation, fear and denial following a diagnosis, meaning that patients are concerned about both the social and physical impact of STIs on their lives. So stigma as a barrier to treatment. There's often various different factors that can contribute to stigma becoming a barrier, such as gender, race, gossip, stigma transference. And so I want to touch on these a little bit today. I'm going to start by talking a little bit about gender and stigma. There often is a double standard in regards to addressing conversations around STIs for different genders. And certain studies have showed that male sexual behavior is often not framed in negative terms, and sexual adventuring is often considered acceptable or even inevitable in young men, while women are considered improper. Additionally, it's found that there is often a common tendency for clinic workers and patients to blame women for spreading the STIs. Race and stigma. Individuals will often avoid being tested for STIs or STDs because they fear discriminatory treatment from healthcare providers. It is important to acknowledge history and how different groups have been affected due to the mistreatment from the healthcare system. The mistrust from the healthcare system, there's already present in marginalized communities, but individuals will avoid being tested because this fear from discrimination, racism, and stigma from marginalized communities may experience in the healthcare system, and this may impact their quality of care, understanding of their personal health risk, and a willingness to seek medical care in the future. Looking at more local examples, Indigenous folks are often, they don't trust the healthcare system due to how they have been treated in the past, and due to the reluctance to seek medical care due to fear of racism. I also want to touch on stigma transference and gossip. Oftentimes, spreading the word is a popular form of retaliation. And in certain studies, it was found that individuals said that if they were to find out that their partner gave them an STI, they would retaliate to spreading gossip or breaking social reputations. During focus group discussions, a lot of people said that they would be angry with their partners and would use gossip, spreading information. And this can often be a very strong fear in small rural communities where there's not a lot of anonymity and word can spread very fast. Stigma and religion, it was found that religious judgmentalism particularly affects women who are cast in the role of actual or expected moral standard bearers in keeping with religious doctrine. There's also a lot of passing privacy and public health concerns. So the location of clinics, whether they are in rural communities or more so located in cities, also is a huge factor that contributes to how many people will often access STI clinics. So if people live in small rural communities, they're very less likely to access STI clinics or resources in that case. So just a little bit on what we can do to prevent or reduce STI-related stigmas. Stigma is often amplified by public health policies and clinical procedures that reproduce cultural, social, and structural productions of stigma, which can separate people into sexual and behavioral categories associated with disapproval, rejection, and exclusion. That being said, I think it's very important to create a safe and inclusive space for conversation, but also acknowledge that there is no one-size-fits-all approach. And Lindy will be touching on a few approaches that she found during some of the articles that she looked at. And I just kind of want to like end this by saying that, like I mentioned, like there is no one size fits all approach, and it is important to keep a very person-centered or trauma-informed approach when you are addressing STI-related stigma and having conversations around these topics.
Based on everything that we have talked about thus far, we do need renewed commitment to systematic, programmatic approaches to prevent or reduce STI-related stigma. And one of those things that is pretty huge in medicine right now is person-centered approaches, emphasizing communication, individuality, autonomy, and dignity of people receiving STI services and really any medical service. Proper staff training in cultural competence, safety, non-judgment, and preventing the negative atmosphere and humility would also go a long way in the stigma, and also making people feel safe, especially marginalized and discriminated groups in the past. And trauma-informed care, the complexity of interpersonal violence and discrimination suffered by people in the greatest need of STIs related services. Registration, sexual history taking, genital exams, sample collections, prevention and treatment discussions are all points where trauma triggering may occur. And that does require a conscious, proactive policy and training and a careful review of procedures and trained staff. Community engagement, a voice for marginalized people, inclusion, and allowing to redress sources of institutional mistrust, as Jonna mentioned at the beginning too, and Rima touched on, like even just in the Indigenous in the past, there is so many sources of institutional mistrust, and exercising sexual and reproductive rights. And sex positivity, less focus on scare tactics or risky or unsafe sex, and refocusing on the importance of each person's sexuality for health and well-being. However, that is safer from an STI prevention perspective. So I just wanted to say thank you everybody for attending.